Okay, good morning. I'm going to speak briefly about transcatheter aortic valve implantation. And this is a little bit of a carryover from the presentation that I gave on yesterday. Okay, so this isn't going to play, but this cartoon was supposed to show you the sapien valve, and with it opening and closing and seeing the coaptation of the valve leaflets. The aortic stenosis etiology, as you all know, congenital bicuspid aortic valve. Then we have patients with rheumatic heart disease and degenerative calcific aortic stenosis. The bicuspid aortic valve I have a special interest in, and this is why I'm showing you this representative panel, because to date the valves that are in clinical use are not being used on a routine basis for this type of abnormality. And part of it you can see from looking at these valves is that the distortion of this valve makes it very unfavorable for the Edwards or the sapien valve to be implanted with its rigid cage and with malpositioning of the valve, and similarly with the Medtronic or core valve being used for these patients. Now, the severity of aortic stenosis, again, this is a review for all of you. It's mild, moderate, severe, and we can see that patients that have severe aortic stenosis or valve areas of less than 1 are the ones that have been targets for this type of technology. Whether or not, once we get more long-term data and smaller delivery systems, we will be using this kind of technology for the less severe aortic stenosis. It's something that I think remains food for thought at the present time. Severe aortic stenosis, the patients that are symptomatic, approximately 50% of those patients are dead within 2 years. And surgical AVR decreases symptoms and improves survival, but yet only about 30 to 50% of the patients actually receive the surgical AVR. The transcatheter valve implantation was first performed in 2002. This was for the high risk or ineligible patients for surgical therapy. Despite that, there's a very high very high mortality at 1 year. Now, it's important to remember some nomenclature. One of the questions I was asked yesterday about compromise of the coronary arteries when we implant these valves. And this terminology that a lot of you may be familiar with, or the sinotubular junction, is a measurement that we have to be very meticulous with obtaining before we enroll these patients in any of the trials, because we have to have adequate distance so that the valve doesn't encroach on the orifice of the coronary arteries. These are the devices. I showed this to you yesterday, the Edwards sapien valve, and you can see that, the earlier generation, 23 to 26 French delivery systems, so quite large delivery systems. Inclusion criteria, as we mentioned before, severe aortic stenosis, gradient has to be over 40 millimeters of mercury, and these patients are usually patients that have symptoms. So, believe it or not, patients can have severe aortic stenosis, but yet are deemed to be too well to undergo TAVI. And so they have to have a high surgical risk, and this is usually predicted by using an STS score with all the inherent problems with the STS score. Exclusion criteria, as I mentioned earlier, bicuspid aortic valve, aortic annulus size or diameter, the ones that are too small and the ones that are too large. There's a newer generation of the Edwards valve that can actually treat these patients with the large annulus size, but for the index procedure or the index study, these were the dimensions that we were dealing with. Aortic dissection or iliofemoral dimensions that precluded sheath insertion of these larger devices, patients that had severely compromised left ventricular systolic function, untreated coronary artery disease, but untreated disease that required revascularization, and then severe AR or MR. We've actually used this technology for patients with severe MR, so I think as the technology does evolve, patients that have severe AR will be candidates to treat with this type of devices. The access for insertion of the valve, transfemoral, it's either percutaneous or cut down, transapical, subclavian transaxillary, and then transaortic. These are, when we look at the access for the valves for the two commercially or available valves right now, the Medtronic valve and the Edwards valve, you can see schematically represented here on the cartoon. This is positioning the valve. So basically what we're trying to do is you don't want to be too high You don't want to be too low. It's like, Goldilocks. You want to have it just right. And this diagram shows that the positioning the valve, and we try to make sure that we can cover all the leaflets, because if you don't cover the leaflet adequately, it will encroach on the orifice of the valve, and you don't want it to be too ventricular, because the valve will actually prolapse into the ventricle, or if there's what we call a bump inside the ventricle, a septal bump, it can actually embolize the valve. Okay, this isn't going to play, but this is an aortogram with a transapical approach. You can see a TEE probe, various catheters, and a retractor in the position of the apex. The valve is positioned. We use rapid ventricular pacing to decrease the cardiac output and to make sure that the valve stays where we place it. And again, this won't play, but what this should have shown you is the implant of the valve from the transapical approach. In the lower right-hand corner, you can see the sheath that's been inserted through a cut down into the left ventricular apex. And from the transfemoral approach, you can see the sheath now up at the 11 o'clock position with the valve positioned across the aortic valve. Rapid ventricular pacing is performed and the valve is inserted. I wanted to show you just one panel that shows the delivery sheath. And what's important is you can see the calcification in the aorta. In this particular patient, you can also see calcification in the common iliac artery. And you can imagine that these are very large devices. You can actually see the calcification moving when you're inserting these devices. And there's some tactile sensations that you get that let you know that you should abort the procedure. So we've actually aborted the procedure before we've gotten all the sheaths in. And we've actually aborted the procedure because of the tactile sensation that we get when we do this. We have hemodynamic monitoring while we're placing the sheaths. So when we ruptured the iliac artery, we know that right away, and we're able to deal with that in a percutaneous fashion. The echo during TAVI is useful as far as sizing, crossing, and positioning, as we talked earlier. And it's also good to use to identify complications that can occur with this type of procedure. This basically just tells you about I'm not sure why the fours are here, but it shows the imaging modalities via fluoro or transesophageal echocardiography. And we have performed some of these procedures, believe it or not, which is transthoracic echo. There's limited data with using ICE or intravascular ultrasound to do these procedures. The presentation that talked about the results of the initial trial, and what's important to look at here is that when we look at strokes, there were more major strokes with the TAVR procedures. When we look at bleeding complications, again, bleeding was higher. And if you look at all-cause mortality and death or rehospitalization, we're very similar in this high-risk cohort of patients. The symptoms were improved with this valve implantation. Echo findings revealed that the hemodynamic benefit was durable. Preliminary subgroup analysis shows that the patients do benefit from having this procedure done. The primary endpoints were met. Death at 30 days was lower than expected in both groups in the trial, and both TAVR and AVR were associated with important but different paraprocedural hazards, and again, more major strokes with the TAVR, but more bleeding complications also with the TAVR. Balloon expandable TAVI should be a standard of care for patients with severe aortic stenosis, not suitable for surgery. Improvements in the device technology and operator expertise will reduce procedure-related complications, and long-term clinical and echocardiographic follow-up will be needed to determine the effectiveness of this technology. This is a team approach. It requires a bunch of specialists to be involved, and whether or not you have this opinion, it still requires a team approach. Thank you very much.
Out of the various approaches which you have described, apical, transfemoral, which is the one which you prefer in your center?
Yeah, I prefer and especially with the low profile devices, I prefer the transfemoral approach, for a couple of reasons. The transapical approach, appears to have more hazards associated with it. In places that have a choice, let's say in Europe, the transapical approach is actually sort of going away. Most surgeons are preferring to use either a transaortic, transaxillary, or transfemoral approach.
Many of these patients are quite elderly and the aorta may be quite tortuous and atherosclerotic. So in such cases, which approach do you adopt?
In the patient with tortuous?
Tortuous aorta, atherosclerotic aorta.
And so the screening process, for these patients is a very meticulous process. The patient undergoes a CT. Actually, they have a non-contrast CT of the chest. They have a CT that shows, or a contrast CT that shows the aorta and the iliac arteries. And the reason for that is to look for the calcification and not so much just on the coronal, but we have to get, sort of cross-sectional views of the aorta for dimensions and for the level and the amount of calcification. And then the non-contrast CT will show us the angulation of the aorta, whether or not there's, dense calcification there. And clearly, some patients can be not candidates for surgical AVR or for a TAVI, based on their anatomy. So I think one of the things that we've learned is that in our zeal to do all of the patients, because this was an alternative, we realized that we can't do everyone, not with the present state of technology.
Thank you.